doctors from Ireland and England who are just going to give us a little talk about how it's been for them so far after graduating at PUMS, from PUMS.
So, yeah, you guys can start. It's fine.
Right. Shall I go? Or?
Yeah, you can go ahead.
Okay, perfect. So guys, my name is Udani and I graduated from the 4-year program at PUMS literally a few months ago, and I did my undergrad in Canada. So right now I'm actually working in Galway University Hospital, and HSE is the NHS equivalent for Ireland. Unlike in UK, the Irish intern year is only 12 months, which is very nice. And in Ireland, there's 6 training networks, and I'm currently working with the West Northwest training network. So when you're picking your Irish networks, make sure you watch such a button and pick the one that you think is so these are my rotations. So I already completed the upper GI surgery rotation, and currently I'm in maxillofacial surgery. And I'll be doing medical rotations from January. So since July, I have been in Galway University Hospital, and I will continue there until January. And then from January onwards, I'll be in Mayo University Hospital. That's Castlebar in Ireland, and that's like 2 hours from, less than 2 hours from Galway. Next one, yeah. So this is how my day usually looks like, and this is a surgical day routine. I do not know about the medical day since I haven't done a medical rotation yet. So you come in at 7:30 and come print the list. So basically the list includes the number of the list of patients who's under your consultant. So at around 8 o'clock, we go ward rounds. That usually takes about 1 hour depending on how many patients you have, obviously. And from 8 p.m., it's all about like ordering tests, getting referrals, getting consults done, and also reviewing patients if there's anything that comes up. And from 1 to 2 o'clock, it's lunch / intern teaching. We do not have intern teaching every day. It's just 3 times a week. And I think it depends from training network to training network. So from 2 o'clock to 4 p.m., it's like following up with outstanding issues. Maybe your patients went for a CT scan, and then in surgical rotation from 3 to 5, you and after that, yeah, after 5 o'clock, you if there's any other issues that come up after the PM rounds, you just work through those and put bloods out for the phlebotomist for next day. And on certain days in surgical rotations, you have surgical day ward. There basically you admit patients, do cannulas, take their history and all that good stuff. Also, you can scrub in if you want. Nice thing about Ireland is, I'm not 100%, this is what I've heard, in UK you're not getting paid for overtime. In Ireland we do get paid for overtime, which is nice. So obviously we will have to do on call as doctors. So in Galway it's called extended day. So basically you stay after your day job after 5 o'clock, technically you stay until 9 p.m. So you have about 5 to 6 of these per rotation. So for 3 months, you'll have about 5 to 6 of these, and you'll be dealing with 2 to 3 wards by yourself. And any issues, you deal with them and then hand over to the night intern if there's any pending jobs. Weekend extended day or weekend call, 8:30 a.m. to 9 p.m. You'll be at the hospital. You will have only one of them per rotation, and you'll still be dealing with 2 to 3 wards, and at the end of the day, you hand over to the night intern. Nights usually start at around 8:30 from 8:30 to 9. It's the handover period, and then you are there until 9 a.m. You deal with a little bit more wards at night, 4 to 5 wards, and you usually hand over to the primary team the next morning. Next one, yeah. So what do I usually do? So basically, you're the first point of contact for anything that's going on in the ward. So the nurses will call you and say, oh, maybe the patient's new score, which is something I actually learned during my electives. It's a national early warning score, which I did not learn in PUMS. So it gives you an idea where the patient is standing, like how bad their score, like the new score will give you an idea about how bad the patient is. So you review the patient, do minor tests that you think are necessary. An example that I took was if the patient has persistently been desaturating, maybe do an ABG before calling the reg. If not, they might not like it. Go back, yeah. Also, you be the main one who's prescribing most of the things in the hospital. Uh, so just prescribe wisely. If you have any questions, you can talk to the pharmacist too. And if there's anything serious, you call the SHO on call or the registrar on call. They're always happy to help you out. And also during on call, you'll be doing a lot of elective admissions. Basically, you do take the history, physical exam, doing bloods, filling out their cardex and all that stuff. And during on call, you'll be doing a lot of cannulas, bloods, and then reviewing scans as well. Next one. Okay, so these are some hands-on procedures that I had to do so far. Like I said, so many cannulas, so many bloods, uh, both peripherally and through PICC lines. And you'll be putting NG tubes in, male urinary catheterization. Most of the female ones are done by the nurses. You don't have to do them. And you'll be removing PICC lines, certifying that. I haven't had one, I didn't do one yet, but that's something that you'll be doing. Also ABGs and VBGs, you'll get plenty of them. And these are on the right side of the screen. I've listed some PICC line, colonoscopy, endoscopy, certain biopsies, cardiac investigations, bronchoscopy. These are the procedures that you usually get consent from patients. One good rule of thumb that my consultant told me is if you haven't seen a procedure yourself, you cannot get a consent from a patient. So if you haven't seen one, even if the registrar tell you like get the consent from the patient, don't do it because obviously you are legally liable. Next one. So some tips I wish I kind of knew during med school, and yeah. So basically, if you have a chance to practice more cannulas in med school, like I know during electives in UK, if you're doing emergency med electives, it's really good. They let you practice cannulas, and even in emergency medicine in PUMS, they let you do cannulas. I think that's an opportunity that I didn't take at PUMS. Also, do discharge letters if your electives allow you to do so. I did a lot of these discharge letters while I was doing my electives in Canada, then that helped me a lot. Also, I feel like logistics of doing everything is much harder than knowing medicine. There's so much bureaucracy and like a process that's involved with everything. So just ask questions if you don't know, and if you do not understand something, just ask around. And something simple is learning how to do ECGs. Like you always focus on reading them rather than actually doing it, but you will be doing it by yourself. And you'll be doing a lot of these during your intern year. So learn how to do them and as well as how to interpret them. Like I mentioned before, if you're not sure how to prescribe something, always call a pharmacy. They're very happy to help you out. If you're working in Ireland, emed.ie is a good website that helps you when you're on call. Pocket Doctor is pretty good. Stethoscope, it's for probably university like interns, but I'm not sure whether it needs a password anymore. But if you think you need it, try downloading it. Might help you out. Up to date has been very helpful as well. And DNF is a lifesaver. Unfortunately, we cannot get up to date in Republic of Ireland, sorry, not up to date, BNF in Republic of Ireland, but in every ward there's a physical copy that you can use. Next one. Okay, so I will not go into that much detail about it. I think we have an event later on. But basically for IELTS, I use the Cambridge IELTS books. And then like there's plenty of videos on YouTube that you can watch. And also I used a website called IELTS Online Tests. I just send them my essays and they did it for me so that I have an idea where I stand. Nice thing about Ireland is you only have to get 6.5 in each section compared to UK, and only 7 overall. So IELTS part 1, basically I followed this PDF. I'm pretty sure some will post the PowerPoint later on, so maybe you guys can access it later on and see what it is. I just pretty much read it and went for the test. IELTS part 2, it's an OSCE. I basically downloaded some OSCE books and practiced some communication stations. And OSCE cases with mark schemes by Shell Meridine was a very decent book. I liked it. So just practice. Only thing is you're not doing any physical exam, just communication based OSCE, like OSCE stations, and just practice. And your medical knowledge is directly not tested, but I think you need to have a certain level of competence in order to answer those questions. Some of the questions that I've been getting most of the time from like people is, did I do any UK exams? I didn't do any UK exams because I'm non-EU. Non-EU cannot apply to UK without PAB 1 and PAB 2. So only thing I did was the Irish exams. Yeah, so that's it from me. Yeah.
All right, so my name is Tito, and I did the 6-year program. So currently I'm an F1 at Lister Hospital, which is in the EBH deanery. There's a lot of deaneries in UK, so I couldn't tell the exact number, but I applied to EBH. It was my first choice, got my first choice. And my rotations are cardiology, which I'm currently still in, and then general surgery next, geriatrics, and then in year 2, I do obstetrics and gynecology, emergency medicine, and GP. Like Udani said, in Ireland, it's only 1 year. I kind of like the 2 years because it offers a lot of diversity. So you do get to mix and see what you want to do. These were my options, so it was nice to actually have the opportunity to do everything before I decide. So next slide. So it kind of seems like we all do the same thing, so I won't repeat a lot of what Udani said. So 8:30 I come in and I prep the notes for the ward round. And then depending on the consultant, the ward round will start at 8:30 or 9. The ward round will end depending on the consultant. Sometimes we've dragged it the whole day, so half the day was spent doing the ward round, which doesn't leave lots of time for the jobs, but it really just depends on which consultant we get. And on cardiology, we get a new consultant every week. So then after the ward round, we'll do teaching once a week, or we'll have lunch. And then the rest of the day is spent doing bloods, booking scans, convincing the radiologist to do the scan, which is known as vetting. Then in my trust, we do TTOs, which are discharge medications if a patient is going home, and then discharge letters. And then by the end of the day, we update the list for the next day and then book bloods for the phlebotomy round. It's nice having phlebotomists because it means you spend less time doing bloods, but like Udani said, try and practice your blood taking, because sometimes you won't be able to book bloods for the phlebotomists the next day. So you guys actually do less on calls. I think I've had like 3 weekends so far. Yeah, Peter's like, yeah. I've done a lot of weekends, a lot of on calls, and I think I had 6 night shifts so far, and some shifts where it's like a long day where I'm not on cardiology, but I'm on call. So on call in cardiology, it's called a ward cover shift for us. So you basically just continue on doing a normal day, and then you're working for an extra 4 hours until about 9-ish, 10 p.m. or 8:30 p.m. So at 5, we have a handover. On my ward, we don't really hand over because our cardiology team is just a small group of doctors. So we see each other, so we just kind of verbally hand over. Then we do outstanding jobs. We review deteriorating patients. Like Udani said, if someone's hypertensive, you review them, see if they need any extra medications. On cardiology, we get a lot of like supraventricular tachycardias, or someone's gone into AFib or something. So it's just about reviewing them, seeing if they actually need anything done. Sometimes you can just leave them, but it really just depends. And then at 8:30, we hand over to the night team, who will then cover and then hand over to the day team if anything's outstanding. So next slide. So in my trust, I don't know how it is in other trusts, if you're doing a medical job, we have medical rotations where we're doing a 6-week block of acute medicine. And basically we're on take. And if you've ever done electives in Ireland or UK, I've always heard on take, and I never knew what it meant. But basically, it's like you're seeing medical patients in the ED. So the emergency doctors will see them, and then they'll decide if they need to be discharged, referred to medicine, or referred to surgery. And because I'm on a medical job now, I'm seeing the medical patients in ED. So we clerk them, basically taking their histories, making a differential diagnosis, and making a management plan. And for me, initially, it seemed like a really like huge thing. Like, I have no idea about anything. I can't make a management plan by myself. But in my hospital, we actually get a lot of support, especially on the night shifts where we're still clerking. The registrar, if you weren't comfortable with seeing somebody, they would come see them with you, or you could tell them about the patient later on, and they can either agree with your plan or add things on. So we got a lot of support. The night shifts that I did, I was covering a ward. So I covered the stroke ward and the acute medicine ward by myself, which was sometimes a nightmare, and sometimes it was all right. But the first night, I remember I was just telling to Peter yesterday, I cried the first night because it was actually quite intense. I got a bleep to confirm a death, which I've never done. A lot of, can you prescribe paracetamol at the middle of the night, and just weird things. But it was actually okay. At the end of the day, you realize that you know a lot more than you think you do. And there's always help. So it was actually all right in the end. So some interesting stories. I mean, they're not really that interesting. I think Peter has some more interesting stories. But we had, the middle one was a bit sad, that we had a man who went into cardiac arrest outside of the hospital. His wife, who did CPR on him, had a subarachnoid hemorrhage from the force of doing the CPR. And so I had to review her during my night shift, and she actually got worse. So she had to repeat another bleed, and her husband sadly passed away. So we get a lot of sad stories like that. But then a nice story, we had another lady who had an out-of-hospital cardiac arrest, and she was on our ward for 2 months, and she would not leave any of us alone. She would come on the nursing station, just like have a chat with us, drink some tea, even though she wasn't supposed to, you know, COVID times. And then we see a lot of rare things like Takotsubo's, which is like broken heart disease, spontaneous coronary aortic dissection. So some really weird things, but yeah. So next slide. So how has it been so far? So far, I've actually really enjoyed my first job. Initially, it was a bit hard trying to find my feet and doing some of the jobs, especially referring to, I don't know, Udani, if you've had like encounters with your registrars. I don't know how surgical registrars are. That cliche that surgery people are a bit kind of rude. I've experienced it because I had to like make a lot of referrals to surgery people and just got like rude answers. But you kind of get the hang of it. You learn not to take everything too personally. You learn how to prioritize, because I got a lot of bleeps during my night shifts or even ward cover shifts, and you just learn how to, you know, prioritize your jobs. It's been great forming relationships with the people I've worked with, the doctors and nurses alike. I think that's what I'll really miss about the ward I'm on right now. Everyone is so lovely to work with, and it's really supportive. We've had some medical students in the last few weeks, so I'm teaching them, and it's really strange because like we just graduated like not too like 3 months ago. So it's a bit strange, but like I said, you learn that you have a lot more knowledge than you think you do. And one thing I've learned is PUMS is actually really good for theory teaching. Although we don't get a lot of clinical practice in, we do know a lot when it comes to the theory side of things. So I would just advise, like during your electives, and if you're in 6th MD, during your summer practicals, do get that clinical practice in, because it will come in handy. Practice taking bloods, practice cannulation, practice history taking, so that when you do start, you're not scared, and you can do things a lot smoother. So next slide. So I applied to both Ireland and UK. I got offers for both Ireland and UK, and I just took UK because I've always wanted to move. But yeah, I'm from Ireland, so that's why I applied. Like Udani said, the IELTS, I did the official Cambridge guide as well, and there's some YouTube videos like IELTS Liz and just random YouTube videos. You'll find them if you just Google it. I think what's been catching everybody out that I speak to is really the essay writing. So really get someone to critique you on your essay writing. Practice a lot of the sample questions that you find in the books and really bring that up. But otherwise, I think it was fine. I think IELTS was okay. Just practice the essay writing. For the SJT, if you are applying to UK, I've put some pictures of the books that I used. I liked the Oxford book more than I liked the other one. I think the Navy one is a bit old, but the Oxford one was quite good. So I did it a couple of, maybe twice, just so I could really, hammer in what the topics were and such. For the Irish exam, in the updated, there's an updated slide. I put a link in, I made like a little short guide because a lot of people were asking me questions about it. So I just made a little short guide. So the guys, the IBSG guys will post the updated slides for you. Your graded exams and PUMS actually play a big part in your applications, especially for UK. It counts for almost like half of your points. So I'd say maybe a lot of you might be in your final year, but if you are just starting, really do try and put effort into your graded exams, because it might make the difference between where you end up. But I think for UK, a lot of people who applied got spots, so I wouldn't worry too much about it. And for the PSA is a prescribing safety assessment test that the UK guys have had to take. I think it's more for when you do start working, but I used past tests and past medicine question banks, and it was fine. So there's a little QR code. I've got it really into my e-portfolio for for our the UK F1s. We really have to put a lot of things into our portfolio. So I've gotten really into it in the last couple of weeks. So if you could just like scan the QR code and then give me some feedback, that would be great. So some tips that some tips that I have kind of took on is to really get to know everybody that you're working with, doctors, nurses, even auxiliary staff. Like I'm friends with everyone on my ward, and that just makes the whole day a lot easier because you banter and it's not just about medical stuff. The medical apps have been like a lifesaver for me, like BNF, Pocket Doctor. When I mentioned I had to confirm a debt, I had no idea how to do it. I had a brief idea, but just the actual steps I had to review. And I used, I think it was Smart Doctor. So I've put the pictures there. I don't use everything on a regular basis. I think the first picture is what I use mostly. When you're in doubt, if you're called to review sick patients, just stick to your like basic assessment, airway, breathing, circulation, disability, exposure. We do it during our emergency simulation days. Like, just stick to that and you'll be fine. Don't be afraid to ask for help. There's always a med reg on call for me, and yeah, I think they're more than happy to help, especially if you do a lot of investigations before you call them, because it makes their job easier. And I think lastly, just take time off, do something that's non-medical, because sometimes it does get a bit hectic and you find that you're getting just wrapped up in a lot of jobs, but if you take time to look after yourself, you'll be fine. So yeah, I think that's me.
Oh, okay, I guess it's me. So yeah, I'm Pete. I'm from UK. I'm from London. I did a 6MD program as well with Tito and with Mike. So I'm based in Trent, which is, if you see on the map here, the deaneries. I'm number 14, I believe. Tito's in number 2, EBH, and then Mike later on is in number 11 in Scotland. Not going to be around the bush. My Trent was my 5th choice, so I put all 3 London ones first. Then I put Wessex and EBH, which is like from Watford, London, that area. And unfortunately didn't get them, and so I got Trent, which I'm happy with. So in Trent, there's two main hospitals. There's I'm in Derby, and then next to us is Nottingham. So I'm starting on psychiatry. Then I have resp, and then urology, and then for F2, I'm in a place called Kingsmill, Mansfield, which is about 10 minutes driving from Nottingham. I've got gastroenterology, upper GI surgery, and then GP. Just quickly, I'll go back 1 minute. Just quickly, when I say this, so London is the most, when you apply here, when Tita said earlier, how sure the IBSG will do a presentation on this next month, but 50 of your points are based on your first 4 years of exams, or first 2 years if you're on 4MD, first 4 years if you're on 6MD. So I was quite like, I was happy just to pass them initially, but to be honest, you should be aiming to get 4.5s and 5s, because then that helps you get to the places you want to go to. And then SJT I'll talk about a bit later. But yeah, but you will get, even if you do have to in clearing, if you don't get a first round, most people get allocated a job somewhere in the UK. So for those people who were asking me earlier, would you rate it on your preference or your score? I would say just put in your preference, because even if you do get into clearing and somehow you end up in a spot in central London, then that's great. So yeah, can you go next? So I'm on psychiatry. I'm on the admissions ward for the county of Derbyshire. So we have about between 15 and 20 beds. There's 1 consultant. It's quite a bit understaffed, not gonna lie. So we have 1 consultant, 1 registrar, 1 CT1, so 1 called trainee, and then 1 F1, which is me. Usually 9 o'clock we have handover from the nurses. Between 9:30 and 12 we have a ward round. For psychiatry, we try and do like 30 minutes per patient, because psychiatric patients are, yeah, they take a bit of time. You have to build a report first of all. You then have to, sometimes they do take their time. If they have a bit of thought block or thought delay, it does take time to properly like interview them and get down to the bottom of their issues. What I love about psychiatry is you have a protected hour lunch break from 12 to 1, which is just great. Yeah, so that's one thing. Yeah, that's one thing we've got over other specialities. And between 1 and 5, we have ward jobs. So usually clerking admission. So a patient will come in, usually on like a mental health act section 2 or 3, or they're informal. So informal, that means they've been brought in. They brought themselves in basically onto our ward. Section 2 and 3 is when they've been either brought in under basically legally. So sometimes we get like police cars coming in, bringing in prisoner. We have 2 prisoners on our ward. We have a few. Actually, I'm not going into detail, but yeah. So there's we've had people from all sorts. People being arrested like an A&E and then brought to us because they were just too aggressive there. So they get. So I'm the first face they see, which is scary as shit sometimes. But what can you do? Other swabs, clerking in, bloods, ECGs. With now, obviously, with COVID, we have to COVID swab every patient. Unfortunately, a lot of patients refuse it because they're in a manic state. Some accept, which is fine. Some, I've had 2 patients try and eat the swab while I try and do it. So I just have to make sure they don't choke on it or anything, so pull it back. Discharge for some reason letters. So on psychiatry, they can range from 2 pages of A4 on Word to about 5. I know the record so far is 7 pages, which was ridiculous. And then teaching. So in Trent, we have on Tuesdays from 12 till 2, we have 2 hours of teaching, which incorporates all the F1s and F2s together. And then the psychiatry on Thursday mornings, we also have like protected teaching time as well. On top of that, I do, in Trent, for some reason, they make us do MAU post-take shifts. So between 5 and 9:30 on some days, on some weeks, MAU is the medical assessment unit, and I follow a consultant just to, people get clerked in on MAU, and then I follow around the consultant and basically write up his notes and where the patient goes to afterwards. And if it's really busy on the ward, sometimes I'll clerk in a patient, do bloods and order results and all that stuff. I think it's good sometimes just because I don't forget all my medical information, medical knowledge, but at the same time, after a long day of 9 to 5 of psych patients shouting, you can get a bit too much. So just, try and relax when you can. On top of that, I don't do a full weekend shift like Tito does, or the night shifts like Tito and Mike will say later. But I've had to do, the last 4 months, I've had to do 3 12-hour shifts on the Sunday, and I cover geriatrics ward, which is still weird. And you're usually the only doctor there. Sometimes the consultant may come, may not come. And it is pretty. The first time I was bricking it. Like I was the only one there. I didn't know any patient whatsoever. I managed to survive. However, on Sunday, last one, I walked onto the ward 8 o'clock, and there was a bereaving family walking past me, and nurses were just like, "Oh, morning, doc. Someone just died. Can you verify it?" And I was like, "Oh, shit." So it's definitely nothing I'm used to on psychiatry, and it was definitely. Thankfully, a consultant came a bit later, so I had a bit of help. Because another patient died on the ward, but I couldn't help them. Sometimes you will be left alone on the ward, and it is scary, but you'll get through it. Next one. Psych's not boring. Of all the stories I can try and think of, I've had I've had patients. I've had a few like threats. Just people, they'll threat all the staff, saying, "Oh, if you change my diazepam, if you change my clonazepam, whatever, I will like kill you. I will smash you up." We've got I had one patient who was completely mute the whole day, didn't say a word to me, tried to do his bloods, and then he just put a fist to my face and was just, "Why are you doing it to me, doctor?" Staring at my eyes, and I was like, "Yeah, just, you're on clozapine, you just need to check, and that freaked the F out of me. We've got a few sexually disinhibited patients. So worst stories once I was trying to get onto the ward. There was a guy just standing in front of the door, unfortunately, masturbating, let's put it that way. So I didn't know whether to go onto the ward or not. So I just kind of stood there, and he was staring at me. So it was really, it was quite scary. But I was fine. Wasn't psychiatry, you don't just dealing with the issue, but you're also dealing with the whole social aspect as well. So you get, obviously, for many people, it's just the families get involved. They've also got drug use. You need to think about what you're going to do with the drug use afterwards. Are they going to go? Are you referring to drug and alcohol services? Are you not? Sometimes there's one woman who she had uterine cancer, breast cancer. She was sexually abused as a child and everything. She'd seen pain clinic and everything, but the only pain that she had was the only way she dealt with the pain was cannabis. So how can you tell a patient who's usually stable on cannabis to tell them to not smoke it? So it's you kind of have to find a balance with some of the patients, which brings me to the next point. You have to establish a good rapport. And also sometimes, yesterday we had a patient faking a heart attack, and he nearly made us call an ambulance. Thankfully he was fine. Today you saw him playing football in the courtyard there is. So I don't think he had a heart attack. And he was 22, so I don't think he was. If you're feeling comfortable, always bring another person with you, especially if they're manic. I had once, for example, earlier when I was trying to take the blood from a patient, and then he put a fist in my face. I have another issue where a woman just started like stripping in front of me, and I'm just like, hang on, no. Always bring another person in, because sometimes, especially in psychiatry, everything's quite legal, and you're always trying to cover your own back. So there's been instances where like a nurse has found themselves one-on-one with a patient, and the patient has been like, "Oh, he hit me," or something like that. And obviously they're trying to usually they make that claim to benefit off it as well. So always take 2 people into a room, whatever you want, because it can get quite bogged down, quite legal stuff. On our hours, as I said, it is very weird. I was usually not usually based in the medical ward. I get called all sorts, medical reviews, verifying death, doing cannulas, ABGs, clerking new patients as well. On those shifts, it's a weekend shift, so all you need to do is just make sure, unless someone's rapidly deteriorating, you're just making sure their care is continued, reviewing bloods, chasing bloods, reviewing swabs, reviewing CT scans, whatever. Reviewing falls as well, that's quite big, especially in geriatrics, so old age medicine. You get a lot of people falling and just making sure they haven't got a bleed in their head. One of the apps Tito suggested earlier, Geeky Medics, yes, just that's a godsend, just use that. It's an app and a website which all the UK medical students use. So try and I would suggest if you're going on medical rotations in Poznan, also have a little look at it. It's very useful, especially when I was verifying the death. I was literally just like, I was ready to go in and everything, and I was just like, oh, so what do I do actually? So I clicked on Geeky Medics, had a look. Oh, this is what I write. This is what I do. All that. It sounds, and also they show you, because half the battle is also not just doing the medicine, but also talking to other staff and recording your notes, because you can get bollocked if you put the wrong thing, especially in psychiatry. If you need to cover your own ass half the time, making sure patients have, when they get discharged, they do have capacity, and if they are threatening to kill themselves, it's just they're just doing it just for attention. They're not actually going to do it. They're just the Geeky Medics always try and do it and just follow what they say. Portfolio is just meh. It is what Tito said earlier. It's so portfolio in UK. It's basically like it's equivalent of that little white handbook we all probably got given at PUMS, and you kind of you feel like it's not important, but here it's very important. It's an online web page, and you basically have a meeting with your clinical supervisor, which is the consultant you're shadowing under your rotation. You have a meeting with your educational supervisor. As I'll answer your question in a minute. And then also you have to do like 15 core procedures during the year, which include like taking blood, or venous ABGs. It's like a spirometry test, always random stuff like that. So you do that, and also you all learn it. So as much as we're scaring you about all these procedures you have to do, then it's fine. Like you will get people will still people are happy to help you. People are happy to show you the ropes. I get given my lanyard says F1 doctor, which basically means that I know nothing. It's an F1 doctor is the lowest doctor possible. So everyone's always happy to help you. Everyone's always happy to like show you give you a helping hand. Apart from psychiatry, where no nurses know how to do any medical stuff. They know how to do mental health stuff, but not medical stuff. Sometimes you are on your own, you don't know what to do. But thankfully for my registrar, she knows some stuff, so it's fine. But yeah, portfolio is important, and to be honest, don't worry about it. And audits and all that stuff, don't worry about it. Each trust has a different policy on it, so just wait till you get there. And there is an induction week when they tell you all this stuff, so don't be too worried about it. Next. Portfolio is just for the internship, Maria, don't worry. Applications, so IELTS, I'm not gonna lie, I took it 3 times. It was, I took it twice in Poznan. I got 7 each time on the writing, and then I did it in London, got 7.5. I think the myth of it's hard in Poznan, the reason why I failed is because I just blamed myself. Like I know I messed up the second time, especially. The first time I went in there just thinking, oh, I'm English, I can do it. But no, wrong. Just make sure you nail the writing. I know Maggie, I know she's not gonna like this, but no, she did a good course for the people who did last year. I know she's in retirement now, but just try and find someone who's just gonna rip apart your essays, because that's the best way to learn. I gave it to my sister, who obviously loves ribbing into me anyway, so eventually got there through her. I used E2 Learning on YouTube. Yeah, E2 Learning. Don't use IELTS Liz. She's useless. And then do the practice papers on the 2 practice papers on the website. SJT, the situational judgment test. I would just focus on one source. I use like 3 sources. I didn't do well on the SJT. I messed up. So I'm the last person you should listen to. But my only advice is focus on one source. Oxford Handbook is enough, because I focus on 3 different sources, and the 3 different sources have like 3 different methodologies and 3 different answers. Ignore them. Focus on the one white book, and then do the 2 past papers on the website. Personally leading up to the exam, make sure you're focused on it. No other side, nothing going on the side. Just focus on the exam, because that exam is equivalent to 4 years of medical school exams. So yeah, all I would say is also so I didn't do, my class ranking wasn't great, and my SAT wasn't great, but I still managed to get a job. So if there's any hope for any of you guys, I suggest do it. PSA, so the prescribing assessment, what's it called? Yeah, well yeah, you're muted here. But that exam, you're fine. You'll be fine. If you start work, as an IMG, you're going to do the exam usually in October. Yeah, there we go. There we go. Prescribing safety assessment. There we go. You're going to do it in October. You're going to do it after a few weeks of working. So you're going to be used to how to prescribe. You're going to be used to all that jazz. So when you do the exam, it'll be fine. Just like PUMS exams, there are quite a few old papers, so you might be able to. You're good friends. Like I became good friends with my fellow F1s, who gave me like some questions that they had in their exam a few months beforehand. Some of those did come up and repeat themselves, so everyone should be easy to pass. Yeah, exams in the first 3 to 4 years matter. I'll just briefly, I don't know, I can't remember if I've gone off slide. Yeah, you're always worried about transitioning from PUMS to UK. I would say your 3 is the same level as them, and might be even more, especially with some PUMS professors like to really go deep on some random ass subjects. I would say that the UK students are better in the clinical aspect. I feel like they, especially I work in Derby, the nearest medical school to us is Nottingham. So you have a lot of Nottingham grads who then graduate and then stay in those hospitals. So they know the doctors already. They know all the where the costa is, for example, in the hospital. They know everything. They know like the guidelines and all that jazz. So it's useful going to them and like asking them for help after, to help what to do. Yeah, just be happy. Ask for help. That's always important. And if you go on electives, and if you go on electives and do some practicals, do cannulas, try and do bloods, do all that jazz. Don't worry if you can't do it. Everyone's happy to help you. At the end of the day, you're there all for the patient. So you'll be fine. And then you can put on your portfolio that, oh, I'm so happy I did my first one. You can put it as a reflection. You can put it as a CPD. You can put it as the case demonstration, something or other. So it's great. Like over writing a deck, you can put that as, oh yeah, I can manage to do it. Fortunately, patient died, but oh, good look at me. So it was good. Yeah, is that all for me? Next slide, I think. Yeah, all right, that's all for me. I'll pass on to Mike. All right, cheers.
All right, hello, my name is Mike, also in the 6MD program. So I am from Canada, Polish blood. I studied in Poland, and I heard that Scotland was a nice place from a few people that had gone there on previous years. And having traveled so much, I wasn't particularly picky, so I figured why not? I'll choose Scotland. I did get it as my first choice, and my general interest in applying to the foundation program was directed a little bit towards psychiatry. So I organized my choices like that, and I did end up getting my first choice. I'm in Dundee and Perth, which is about an hour from Edinburgh. And I've got psych of old age, internal medicine, which will be infectious diseases. I might have to do some cross cover with Team COVID at some point, who knows? And my final placement's in trauma and orthopedics in Dundee. I don't have my second year, the FY2, established yet. It's basically about in December, it's another application process. You're not at risk of not getting it. It just, you're again being ranked to see which one you do get. Typical day on old age psych, pretty similar, nothing too unusual. The handover, we get a few hours for job completions. So the usual bloods, ECGs, reviews. On old age, a lot of the reviews that we get are someone from the night staff has handed over that one of our patients fell, hit their head, or fell, landed on their hip, and you need to go and make sure that they're okay. I find that the psych of old age is a bit more of a medical job than it is a psychiatric job. I cover 3 wards, 2 of which are dementia wards. So we don't have the daily ward rounds, for example, discussing things with the patients, because on the dementia wards, you can't have a conversation with these patients. Like they'll mumble things back to you. They have adults with incapacity in place, so they have guardians and all of that set in stone. So we have a few hours worth of jobs, 12 to 1. So it's protected time, but the way it was presented to me is that it is the patient's time to be protected from us as doctors. And we have just claimed that as our lunchtime, which is pretty great. And then for the rest of the day till 5, I mean, we're employed from 9 till 5 for at least the psychiatry job, though I don't think you can reasonably be expected to finish every day at 5 on the dot. I think there's a little bit of understanding that if something comes up, you stay a little bit longer just to ease things on whoever is taking over. Within reason, of course. You're not going to stay hours late every day. Throughout that work week, there's multidisciplinary team meetings. So that'll be with psychology, occupational therapy, physiotherapy, that are all coming and seeing the patients just the same as we are. There's various family meetings to discuss future plans for the patients. Like when they are ready for discharge, are they going home to their relatives? Are they going to a care home? Or I guess those are the 2 main choices, really. There's various outpatient things that I can go to. A lot of it hasn't happened too much recently because of all the lockdown and travel restrictions. But I did manage to go on a couple home visits. They were to diagnose people with dementia. Yeah, they're outpatient clinics. So I saw people come in and I got to interview them. And I also, on my job, I don't do any extra hours on the psychiatry, but I have to do, throughout the 4 months, I have to do 21 night shifts in the acute medical unit. I think that'll be on the next one. Okay, so 21 nights. Might as well jump to the next one as well. The consultant's the only one who can modify actual psychiatric medication, but all the medical stuff me and my team handle. My team is me, an FY1. We have a GP specialty trainee, and we have 1 locum. And then it's just a consultant. But there are various interesting things that happen on psychiatry, and there's some interesting stuff that happens on AMU. I think from a physician learning point of view, the night shifts at AMU are probably more useful and productive. But in terms of transitioning to the role of an FY1, I was very happy to have psychiatry as my first job, because the workload on a daily basis is much smoother and less demanding than the AMU or a surgical job would be, which gives you a bit of time to adjust to your role rather than feeling maybe as much being thrown into open waters. So the night shift, 9 to 9, nothing fancy, a little bit of a handover, and then it ends up just being me and a reg managing all of AMU. Actually, I heard Tito say in her presentation that she goes to the ED to clerk in the patients. Is that right? Yeah, okay. So for us, they come up to AMU from ED, and then I basically have to re-clerk them in. Yeah. So I don't know if it's the most efficient means of doing things, but I mean, that's how it happens. All the usual bloods, ECGs, if their oxygen stats are dropping, you're doing an ABG, cannulation, catheters. I've actually had to do female catheterizations as well because as much as most of them are done by the nursing staff, sometimes you'll hear no as an answer, and you're like, but why? Come on. And then PR exams if you're suspecting it, but that's usually not a night staff concern. If that comes up, you're okay, you know what? That's a day team can handle that issue. We're really short staffed this night. It's just me, so there's no active bleeding. They'll be fine. And that is the big thing of on the night, you are there just to make sure the patient lives till the morning, more than anything else. You're not there to solve all of their problems. We don't discharge people during the night, so not a lot of EDDs happen then. But it's not as calm as you would think, because I would hope that if someone comes to the hospital at night and you manage them and they settle down a little bit, that they might want to get some sleep. But that doesn't seem to be the case. They're just up and at it all night long. Very bizarre interactions. In the morning, there's handover of if you didn't finish anything, you can pass that on. And then there's a registrant as well. Though they're busy managing other things, managing very acutely unwell people. So they're not always with you. And it's just if you have anything very urgent. And I've had a few of those where, for example, I was just casually strolling in to clerk in a patient who came in for an unwitnessed collapse, right? On my way there, one of the nurses, oh, hi, can you give us a hand, please? Seems this guy, random side room, this guy is seizing. Okay, sure. I had seen someone like that before, so I wasn't too particularly scared about it. But I have found that, anything that happens, nursing staff, they do get quite concerned if they see any dangerous signs. Obviously, this one was warranted because seizing is never a good thing, especially if you're not an epileptic. He ended up being okay. It was old man came in with a urinary infection and ended up seizing. We had prepped the diazepam in case he was seizing for longer than 5 minutes. And me knowing to prep the diazepam is information that was provided in something that I'll cover later on. And yeah, I guess there's a few things that I'll cover there. All of the procedures, like the actual clinical skills, like taking bloods, doing ABGs, cannulating, I had done none of that, not even once, prior to showing up to the FY1 job. So all of it was learn on the job. And they're going, like, as you study for these, I think the SJT, they recommend like the good medical practice and whatnot. And they say, see one, do one, teach one. And I've found that has been proven true, where I'm like, okay, I've never done this before. Can someone please show me how to do this so I can see it? Yeah, that's fine. And they show me once. Okay, cool. Now I guess I officially know how to do this thing. And from that point on, you just do it. And it becomes a bit of you do things because you know they need to be done, even if you're not incredibly confident in doing them. You just know that the patient needs this and it needs to happen. And there's no real magical skill about doing a lot of it. It's just a matter of repetition. How's it going so far? I do enjoy my placement. The psychiatry during the day is, I would say, quite calm. It does get busy, but not a lot of dramatic things happen. I caught a neck of femur fracture on an old man who fell the other week, which, poor him, but it was satisfying for me to catch it. Because, okay, I do a lot of falls reviews, and it's every time, okay, they're fine. What are we going to do? We're just going to keep an eye on them, see how they do. These people are not for escalation. If anything were to actually genuinely go wrong with them, a lot of the times there's not much you would do because their bodies are too frail. But you know, if you do enough repetition of this one thing, then when you see something unusual, you're like, oh my God, this is it, right? I've been preparing for this the whole time. But yes, so psychiatry is a smooth transition into the FY1 role, I think, because the workflow's a little slower than an AMU or a surgical job, and that gives you time to familiarize yourself with things. I'm grateful for the night shifts. They're not always pleasant, but I am grateful that they're there. I do get to learn. Figuring out, for example, the electronic systems, how to navigate through all of them, what they even are, what some of these abbreviations mean. When you show up on a medical job and you have this list and they're just tic-tacking boxes and you don't know what those signals are, a lot of that is something that we as IMGs need to learn, but you just learn that on the job, and it's a matter of knowing that there are no stupid questions as an F1, especially not as a fresh F1. No one really on anywhere I've been has had any like major expectations of someone coming fresh onto the job. Obviously, if you show up 6 months into the job and you're asking them, what are these ticked boxes? They'll be like, haven't you been working 6 months? Like, how don't you know? But yeah, definitely logistical things were the biggest things to adjust to. You know, who to call, how to find the referral finder. Yeah, I would definitely recommend being friendly with all staff, absolutely. You never know when you will need a nurse to say yes to one of your requests instead of a no, even if it's something that they're not necessarily responsible for. Sometimes you'll just need an extra pair of hands, and you'll really hope for that sacrifice of theirs. Don't be afraid to ask for help. I haven't had any situations where that's been taken negatively. In fact, people are grateful that I'm asking now so that I'll know it later on, rather than forcing myself to figure it out. And especially with all the IT stuff, navigating through the systems, you might feel stupid asking, how do I order a head CT, right? But then rather than spending an hour ordering the head CT, you will ask them, how do I order a head CT, find out in 5 minutes, and you can get on with your business, and you've learned. Yeah, okay, next slide. Tips. I would definitely advise practicing clinical skills wherever you can. It's very doable to just learn it on the job. That's how I did it, and now I'm very confident with all of the ones that I have done. But that's definitely a difference between us and the local graduates. Most of the seniors will realize that IMGs aren't necessarily exposed to it as much. Some of them are more understanding, some of them less, but it's not a new thing that IMGs are showing up into the foundation program. Second tip is to take a few deep breaths before you see someone who's deteriorating. Panic is never helpful. A clear mind is always helpful. And rarely is it a situation that you can't take a moment to sit and think about it. If it's a situation that you can't do that, then that means you're not the person for the job and you should be escalating immediately. and yeah. Yeah, the third one, the news score can look scary. So this was mentioned, this news score, and basically it ranks various things like blood pressure, respiratory rate, pulse, their temperature, whether or not they're on oxygen, their mental state, and sometimes these numbers, if you see a patient with a news of 3, then the nurses are, at least on my psychiatry ward, they're required to do hourly observations, which is quite intense for them to do it that frequently. And on AMU, I think the most they go to is maybe up to 2 hourly, something like that. But if you see a number like 8, usually a registrar needs to get involved. However, I've had situations where I'm sitting waiting for the next patient to come up in AMU, expecting them to be fine. Like, okay, it's a non-infective exacerbation of COPD. So I was expecting their lungs to be not great. Let's put them that way, just because this is being recorded. So I'm sitting, I'm waiting, and one of the nurses comes up. Okay, your patient has arrived. By the way, she has a news score of 7. I'm like, okay, that's not good. I did all my pre-clerking. You will do pre-clerking, as in you have some time before the patient comes up to prepare their medications and the Cardex, which is basically a sheet of paper with other list of medications when they're supposed to get it, all of that. And then that's what the nurses use to actually give the patient the meds. So I go see the patient, and it is like she's breathing through a straw into a glass full of water. It's just gurgling. She's sitting there and gurgling. And this was my first time seeing someone that had actually deteriorated. This is on my first night shift. So, you know, heart's beating fast. I'm like, okay, what do I do? How do I prepare for this? And it was definitely a learning experience because I was concerned and I notified the reg, right? I think I was lucky that the reg was available and they gave me some pointers, but it was something that, you know, this patient, if you went and you looked at them, you're like, oh my God, this is bad. This is really bad. But if you were to take a deep breath and realize that I don't need to run and try and do chest compressions immediately, like they're still sitting there and aware, right? So you have a moment to sit and think, okay, they came in here with exacerbation of COPD. What do they need? And I have here formulary is gold, right? And that's essentially this very similar to BNF, but it's localized to your region, to your hospital. And you can look up a treatment summary, right, of what they need in acute exacerbation of COPD, right? So you look that up and it tells you they need various nebulizers, they need to make sure that they've got the good oxygen, right? And you just write those things into the prescription sheet, you tell the nurses you wrote it in, they give the stuff, you wait 15 minutes and the patient's fine, right? Obviously, it doesn't always work out that way, but second example, man comes in, same night, next patient. Man comes up, they're like, okay, he's got a news of 8, and his oxygen saturations are like 85. He doesn't have COPD, so this is not a normal target range of oxygen saturations for him. And he's breathing really quickly. Okay. But I just saw someone with a news of 7 that I majorly overreacted to. So is this 8 really that bad? So I go see him. Already skepticism in my mind. I open the door. Hello, sir. Oh, hi, how are you doing? He is sitting there comfortably. So clearly, at this point, the news was not accurate to the actual clinical state of the patient because looking at the trend of the news. So it turns out he's been sitting at 8 for the past few hours. All right, so for him, that's nothing new. Yeah, just something to keep mind of. It's okay to ask questions. Yes, we're not expected to be all-knowing. That's what the reg is there for. Absolutely. Any questions, I always just ask a reg or ask some sort of a senior, someone above you, because a little bit of experience goes a long way. Yeah, should be good. Okay, before I go to exams, because this will be my last slide, of a few nice stories from psychiatry that are much more calm. So this is from the dementia wards, and you sometimes get called down to do some reviews that you don't understand why they would be reviews. So I get called down, please review this man's foot. Okay, but why? Right? Didn't get explained over the phone. I show up. Yeah, so it turns out this guy, who is wheelchair bound, by the way, isn't able to stand up and walk around, was found with his foot in the toilet. How did he get his foot into the toilet? You can't posture yourself to get your foot into the toilet without having the strength to stand up. So I don't know how he did it, but I also didn't need to review his foot because there was nothing wrong with it. They're just like, we don't know what to do because his foot was in the toilet, so let's call medical staff. There was that, and then we do have some aggressive patients, and actually an interesting thing about the dementia that it was described to me by one of the consultants is it is a loss of inhibition of certain things, right? So if some person's inner character was aggressive, but they've been holding it back through various coping strategies and general willpower, then if their dementia progresses, what can show as their primary personality could be that aggression. So we've got this one aggressive patient, and we have one very frail little patient. And both of them were in the courtyard together. Nurses were watching. Suddenly, all we see is the aggressive patient. What happened to the little frail one? Nobody knows. They go into the courtyard. And then all you can hear, then when they open the door into this courtyard, all you can hear is, help me, help me. And there's just this poor, sweet, frail lady laying in the bushes, just curled up into a ball. Oh, she was fine, okay? She was absolutely fine. Nothing happened to her. But yeah, that was kind of interesting. Okay, exams. So I'm not keeping you guys too long. IELTS, so I'm born and raised in Canada, so I relatively ignored all the other sections other than the writing bit. I did use the Cambridge book, so that gave me an idea of what the exam would look like, but my main focus was on the writing, as I imagine everyone's really is. Don't think I really have any solutions for it. I tried to write formally. I got the 7.5, and I'm glad. With the SJT, Oxford Handbook, I thought was good. I did try using some other books, but the quality of their questions never seemed on point. I felt the Oxford Handbook, the structure of the questions was most similar, as well as the old tests that they have on there. As in the official old tests, I think the official old tests are the closest thing you'll get to the actual exam, and understanding their reasoning and rationale and the ranking of each of the options against the other ones. But what you'll find on the old tests is that, how early did you start prep for the SJT? Oh goodness, SJT was in January, so I think I started, yeah, about a month, I would say. I did my electives during the summer, so I had the last few months of the year free. So the old tests here on the site, all of the answers to the question will be from the same category. So for example, to talk to an FY1, talk to a nurse, talk to a consultant. right? They're all regarding talking to staff members. But what I found on the actual exam was that you would have a similar style question, but each of your answers would be from a different category, right? And I found that was the hard part, to mix and match options and ranking them from different categories. Something to keep in mind. I don't think was particularly difficult because of this glorious video. Like, I'm telling you, you click this link and you will do swell on the prescription exam. And yeah, time on the words, because I think in general prep for the PSA, there's a lot of talk of how you're writing your prescriptions. Being on the wards, I think I had about a month of time on the wards. You definitely are familiar with the structure of how to prescribe on a Cardex, and that would very much so be easier to actually do it. And the PSA book. Yeah, thank you very much.
All right, I'll quickly just run. We'll finish at 9 o'clock. I'm just going to quickly run through the questions you guys sent in. Yeah, Tito and Adani, just mute yourself so you can quickly answer these questions. If you feel you need to answer, just do it. One of the questions was, can you support yourself only from the money from the internship? Yes, but don't expect to be living in Wojskowa or Łańska, so enjoy that life as much as you guys can. Enjoy the Uber Eats, enjoy the Uber as much as you can. You won't be able to. And of course, if you live in like London or some bigger cities, you'll get slightly extra pay, but then it's more expensive to live there. So, yeah. Can you hook us up with any electives, please? No. I'm sorry. As much as we can stamp. Yeah, it's recording. Oh shit. Yeah. If you want to show us some stamps, then maybe. But electives, like, they're not even. They're being very restrictive with, for me, Nottingham students. So it's going to be difficult with you guys. So that'd be hard. Is it the same in you guys, or? Yeah, I guess it's going to be hard. So electives wise, just trying to do it in Poznan as easiest as possible. Peter, why did you choose EBH?
I wanted to be kind of close to London, but not in London, so I just chose EBH because it seemed to be close enough to London that I'd still be able to be close to people I knew. So yeah, that was the primary reason.
Do you get paid during your internship in UK and Ireland? Yes, you do. Don't worry. Yeah, if you want an exact figure, go just look online, and hope. Yeah. Does it matter? My clinical skills are 0. I can't put a catheter or cannulin. Yeah, you've heard from all of us. Don't worry. You're fine. I graduated 6MD at PUMS. I passed the LEC, did my stage to get a Polish license. I'm licensed to be a doctor. How do I become a doctor in UK? So with that means you can bypass F1 in UK, so you can go straight into F2, and there are some standalone things in F2. On that front, you need to go. I think it's the GMC website or NHS Jobs. I believe you can go through there. I know.
I think you also applied through Oriel, because I remember seeing F2 standalone posts on Oriel when we were applying for F1. So, yeah, I suppose just Google. You'll probably find some way. There's a pathway somewhere.
And in Ireland, you can bypass this year, which Adani's doing. So you can go straight. Because I know there's that. I know you can't apply for your pathway, Adani, can't you? If you've done a year, can you?
Yeah, you can. You have to finish both. From UK, you have to finish both years before you can apply.
Yeah. What do I need to become a doctor after graduating in Poland? Do I need to do stage? No, you don't need to do stage. You don't need a Polish license. So after so in your second last year, you need to do your IELTS. In your last year, then you have to do the SGT and sign up for Oriel and everything. That's IBSG doing presentation next month. If you really want to know, go just honestly Google it. It's so much easier. Would you recommend familiarizing self with electives? Do you expect to know how to use certain systems? Problem is, certain systems and softwares, each of our trusts has different software, so don't bother about that. Mike said, and as we all said, just ask someone for 5 minutes learning, and then they will teach you how to do it. And then once you learn, the teach one, do on, and then learn one, teach one, do on.
if you're asked something once, you're going to be asked it multiple times. So it's better just know right off the bat.
Yeah. Once you do it, it's fine. All Gucci. Dr. Adani, what are the best tips and advice for the IEET exam 1 and 2?
Like I mentioned, that PDF, go through it. That's what I did. And just know about like the usual ones, you know, like handing over patients, how, like, what would you do, stuff like that, like the usual hospital work ethics kind of. I think you will learn a lot of that during electives. And then for IET part 2, it's basically just practicing communication ones. Just find some Mosky books. There's a lot available online. You can download them for free and just go through them. That's what I did. I just practiced with my family.
I think for part 1 as well, there were a lot of random questions about the HSE, like legislation and guidelines. Like Udani said, in the PDF, it will like link you to those legislations. But I ended up Googling a lot of just random things like consent in the HSE, like what are the rules and regulations about those things. There was a question about the news score as well. I don't want to say like the actual question because I can't really do that, but there was a question about the news score and sepsis. I remember there was one about child protection as well. So just random things like that. Google. I put like a list in that document that I'll get the guys to share later on for anyone who's wondering.
Okay. Transition, I feel like we've all said it quite thing. Best way to choose deaneries. For me, just purely because I'm from London, I wanted to go nearly around there. The rest of you, there's a website called Messly, I think. I don't know if you guys looked it up. It's Messly and it kind of ranks each one. Depends where you want to go to. It's all, yeah, just look it up and just be wary. In London, it's quite, London's the most difficult to get into and it'd be expensive to live in. You're going to be, around the Queens every day for lunch or something. You're not going to. Deaneries, IELTS here, he said, portfolio building, you'll learn it during your year, so don't worry about that. Research and audits, it's usually good. I think it's quite, in my deanery, they, especially because in psych, a lot of things not as busy as other wards like Tito's on, so you can do quite a few audits. You can do a few audits. I know in pediatrics, in my unit, you have to do an audit in order to pass your 4 months. I'm doing an audit at the moment. Research, I think you just need to be at the right place, right time, but there is opportunities. I think there's more opportunities there than there were in PUMS. So, all that. Preference-based, lowest points accepted or where you wanted to go. I did where I wanted to go, and just, around as possible. Right, someone sent in, Jesus Christ, a long list. I think we've answered most of it. Interview process, there were no interviews for us. Ireland, was there interviews? No. Maps, we talked about it. My work-life balance. Well, thankfully we've got a great thing called COVID, so I can't do fucking shit. Like I just go into the gym, but god damn it, they closed. Yeah, sleep, it varies on your schedule. I'm thankfully getting a good amount. Friends, what are they? My family, I try and see them when I can, but whatever. Food, there's always an M&S in a hospital or a Costa, so.
Costa.
Oh, Costa is live, get the app.
I've really got into coffee these days.
Oh, and the Christmas menu is out this weekend, today, so, just all stock up. Departments, we said, living arrangements, I live privately. You guys all live?
I live in a house share. I have my own room.
But none of us live in hospital accommodations, right?
I know a few people in hospital accommodation, but it's not the best.
I wouldn't recommend it.
No,
I've heard some horror stories about it.
And in Ireland, they don't have any hospital accommodation. You have to find one for yourself all the time.
All I would say, so I live down the road from my hospital, and and not down the road, but I live like a good 20 minutes, 25 minutes walking from my hospital. And unfortunately, because I do psych, I do notice all the psych patients sometimes walking up and down in front of my apartment block. So when you see them, especially like in the middle of the night, you're like, oh shit, you should not be here. Especially the ones who threatened me, but that's how I think. When did you start working? We all started August?
Yeah, August 5th.
August 5th, yeah. That was
I started in July.
When were you, Dani?
July.
July.
First week of July, I started, yeah.
Has your hospital adequately protected you from catching the virus?
Definitely.
yeah, they have. Yeah. I was put on the COVID ward without them telling me, and then like literally I saw one patient just in a mask, and they were like, "Oh yeah, he's positive." And I'm like, "What the fuck? You not tell me anything?"
Why are you seeing patients without a mask?
And I had a mask on, like a proper, PPE. Like
but you don't need proper PPE though.
Okay, right. Listen, right. This is my thing. Because they tell us if you try and do CPR on a person, make sure you're wearing full PPE.
Yeah, if you're gonna do anything that's gonna make droplets, then you wear full PPE.
Anyway, fine. I had to get tested, and I'm all good. After a couple of months, yeah, I feel a bit more comfortable. I think we can all agree we felt a bit more comfortable. What tasks more difficult? Yeah, I think we've all mentioned it. Resource PSA, I think we've done it. eMedica. Everyone know what eMedica is? No, so don't use it. Resource SJT, we talked about it. Your scores for SJT and your ranking scores, I did shit. So,
I got in the 40s. I literally cannot remember the exact points, but I got in the 40s, and then plus your academic score, so that helps. Like Peter said, it's like about 50%. So I think that put me at like 79, 80 or so. So I got my first one with that. But then again, like Peter said, I think you'll get a job no matter how well you do. It just depends on where you get, really. Mm-hmm. So if you're not picky, don't really worry about it too much. Just do your best. But if you do want London, I mean, you're gonna have to put in the work.
I feel like even for London, you might need those both research papers. You get extra points for having secondary degrees of various kinds. So if you're really going for that top spot, you need to push the limits of your achievements.
Yeah, I messed up. I got like 69 or something. I got like 10 points, but I got a job. That's the important thing. I mean, and then no one, at the end of the day, no one gives a shit. No one, you're working there side by side.
No one's gonna ask you.
So, people will be like, oh my god, you studied in Poland. Oh my god, I went on a lad's trip to Krakow, and I'm like, oh great, what did you do there? Oh, we went to Auschwitz, a bit sad, but then we went for the piss up in Rinnek, and you're just like, that's Poland, Auschwitz, and cheap booze. All right, sick.
One of my consultants was Polish, so he got me talking about ECGs in Polish, which I naturally could not do, but it was nice to like bond with him in something that was a common ground. So it's handy.
Yeah, my first uni was all London. Obviously, I didn't get them. And my Trent was I think it was my fifth or sixth. But you get a job, we're all working. So yeah, I think we've got 4 minutes to spare, guys. I think I think we've answered all your questions. Is anything in the chat? I know this has been lengthy. But we're all surviving, we're all alive. That's the important thing. And it's tough work. So enjoy. I know you can't really enjoy Poznan at the moment, but when you go, if you're not feeling that one beer in Rinnek, just go. Just go, because you will regret it when you can't do that anymore. Mm-hmm. You want to order that pad thai from what was the place called?
High Walk.
High Walk. Just do it. Order it.
I miss that time.
Oh man, I miss it as well. Just do it. Still need to complete MCCQE exam for specialty training. Yeah, you need to do all. I think in second year, and people are now doing an F3 as well. So they do like they take a year out after F2, and they do either locums or they do some like special fellowship things. So you have time to do time and study for those exams as well. Yeah, awesome Canada things. You can do internship. Yeah, I think that's. I don't know if you guys have anything more to add.
I think the clinical bit, just because a lot of people have been messaging me about that. I mean, if you can get the practice in before you start, it does make it smoother, but don't be scared if you can't get anything done, especially because of COVID. It's probably going to be hard with electives and things. People are really nice, especially in hospitals. You'll find that there's always another junior or someone who's going to be willing to help. Like Michael said, if you just tell them, no one's going to judge you. I can't do this. Can you show me? They'll help you. So don't be worried about it. Of course, get the practice if you can, but otherwise you'll be fine. And we do get these things signed off, like Peter was saying, in our e-portfolio. So you'll have the whole course of the year to learn it and to sign it off. So don't worry.
Yep. I think that's all from us. Lydia, Danielle, do you have anything? Or we?
Yeah, I guess if no one has any more questions, we can finish up here. So I'd like to say thank you to everyone for joining us for this event, and thank you so much as well to our speakers for taking time out of your busy schedules and doing this for us. So it's much appreciated. Just 2 announcements before we go. So we will post the presentation, hope either on the event page or IBSG page, so just be on the lookout for that. And we'll do in December as well a more detailed presentation of the actual process of applying. So I guess if no one has any more questions, we'll end the meeting here.
Yep. All right.
Okay,
Cheers,
grand. So thank you very much again, everyone. Bye.
Thank you.
Stay safe.
Bye.
Oh my days.